I entitled my presentation Teamwork. I'm really grateful for this award. I'm grateful for the people who voted for me to present this award, and I'm grateful that this award is named after John Goldman, who supported my career very much, as you have heard. Therefore, it's very nice to receive the award under his name. But teamwork is important for all of us, and this is my topic for the next 15 minutes. You have heard that I had the chance to enter Rüdiger Hehlmann's hospital in Mannheim in 1990, and very early, during the first year of my stay in Mannheim, Rüdiger Hehlmann asked me to help him with the CML Study 1. He has 3 years before, he has founded the CML study group, the German CML study group, and CML Study 1 was, as he always says, the most boring study in history, comparing Hydrea with busulfan. But the early results were very exciting, and I had a chance to participate here just as a monitor. I started monitoring this study, and you see that Hydrea had an advantage over busulfan, and this was, in our interpretation, due to the more stringent treatment. That means you had the chance to lower the leukocytes to normal levels, which was not the case with busulfan, and this resulted in a better overall survival. The next stage was the comparison with interferon. Interferon was advantageous over busulfan, but not over Hydrea. And the colleagues in Mannheim accepted me very fast. That means I was part of the team, and I realized what teamwork means. When you do a trial and when you create a study group in your hospital, it's important that you have the backup. And the backup are people who are not so close to clinical or basic research, but they do the clinical work. And that's all important. All these people are very important for the success of the work, and therefore I'm grateful to all of these colleagues here on this picture, the colleagues in the clinic, in the lab, and in the study center. So the next step was to look into the details of the current stage of, or the stage of CML treatment. That means allogeneic transplantation was the only chance to cure patients, but we knew that a lot of patients died from this procedure, and it was a question, what are the reasons for dying? And we realized, looking at the data, that when interferon was given very close to the allogeneic transplantation, this was disadvantageous, and we created this 90 days notion that interferon should be discontinued 90 days prior to the transplant. And then we compared, together with the IBMTR, the transplantation results with the results from the German CML trials, and you see the disadvantage of the transplant in the early years, and then, of course, the cure from CML at a later time. I think this was a very important comparison, and Bob Gale helped very much with this comparison as a director of the IBMTR, and he published it, and therefore you can imagine this was my first encounter with Bob Gale that time, and now we have worked for 10 years, more than 10 years, as editors-in-chief for leukemia, and we have a nice and very frequent conversation as in this position. I went to London to do clinical research, very close to the clinical part of the Hammersmith Hospital, and we decided to use a methodology which was introduced by mainly Nick Cross and also Tim Hughes, the competitive PCR into the interferon patients. And I collected a lot of samples from the German studies, brought them to London. It was very difficult with the customs sometimes that time to bring all these samples in GTC to London, and did competitive PCR, a very, very cumbersome method. You need at least 15 PCR reactions for one data point. But we managed it, and we found that we see a correlation of PCR, quantitative PCR results with cytogenetic response. And we saw, and this was very interesting, that the quantitative data for the complete cytogenetic responders had a wide range of residual disease. And we checked whether this wide range of residual disease dictated the outcome. And actually, the patients with a higher load of residual BCR-ABL transcripts had a higher risk of relapse. And I'm very grateful to my friend Andreas Reiter, who was in Mannheim that time, who sent me all these samples. We were in close contact between the clinics in the Hammersmith and in Mannheim and the lab in London to perform this analysis. So, and then we compared, and this is of course a question of cure, whether the interferon-treated patients had a similar chance of being cured as the patients after bone marrow transplantations. Jorge Cortes may remember the nice scientific discussion which we had with Moshe Talpas on the level of residual disease. He claimed that the negative PCR results were a marker for cure. And I challenged him. I tried it. I was a little shy, of course, but we had a nice discussion at ASH with that, and I showed him these results, and he was very interested in it. And this introduced the quantitative PCR into this area of drug-treated CML patients as well. And John Goldman took this discussion very serious, and he said, why are these patients not cured when they are in stable remission after discontinuation of interferon? This is an operational cure. This is not a biological cure. This is an operational cure. They are off therapy, and François Mahon did the same in France. That means we had a set of data internationally which prompted the idea of treatment-free remission, here based on interferon, but of course this was the basic data, the baseline data for our current treatment-free remission studies. And then it was now in around 96, we had a big meeting in Mannheim, the so-called IRC-LRD meeting. This was the society with the longest name, Comparative Research on Leukemia and Related Diseases. I had the chance to work as an assistant of Rüdiger Hehlmann to prepare this trial, this meeting. And we had a guest. The guest was Brian Druker. And Brian Druker introduced a new drug here, which had a longer name. It was a Ciba-Geigy drug, but actually it was SDI 571 later. And then we had later a meeting in Jerusalem, met with all these people who are famous of CML basic research, John Groff, Nora Heisterkamp, and others. And all were very excited about Brian's data with the introduction of imatinib, and you know, of course, the results, the second-line data published in the New England Journal. And then the Big Bang. The Big Bang was in 2001. The paper by Charles Sawyers in Science describing the first mutation, T315I BCR-ABL. Charles was thinking that this is the only Achilles heel of BCR-ABL and of TKI, and he was right with the mutation, but not right with the only mutation. We collected here in Europe, in several labs, other mutations. First the P-loop mutations, and then others, and we joined. We put our data together from France, from United Kingdom, from Germany, from Austria, and from Italy. We put this data together and sent it as a letter to Science. And this was, of course, the first joint effort to challenge other data and to add additional data. And this was teamwork. This was real teamwork here, and we were successful with that. And the rest is history. You know, of course, the data which were published later with imatinib, later the CML4 study with a higher dose of imatinib compared to the standard dose. And then we came back to interferon. Has interferon still a role? And we did a study with a combination of pegylated interferon and nilotinib. And we discontinued first the nilotinib and in the second stage the interferon. And the results from this pilot study were remarkable. You see here treatment-free remission data. The upper curve shows data on interferon only, the lower curve then after discontinuation of interferon. And this was, of course, the start of our thinking of an interferon maintenance therapy, and the background for the Tigers trial, which started in 2012, nilotinib versus nilotinib plus pegylated interferon. You need time for such a study, and we needed 10 years. The study database will be closed next week, and we will analyze the data. And I'm looking forward to the data. We have two endpoints. One is the endpoint whether the combination therapy will create more major molecular responses than the monotherapy. And the second one is, of course, the question of treatment-free remission after pegylated interferon maintenance therapy. And it is teamwork again. We needed 110 sites in Germany, in Switzerland, and in the Czech Republic, who recruited 717 patients from academia, from local hospitals, and private practice physicians. And we have heard today already the data from mutation analysis. That means based on this teamwork here, we had the chance to do next-generation sequencing, and we saw these mutations, most importantly A6L1, and A6L1 has an impact on the achievement of major molecular response during the study. Now asciminib. Asciminib has been in clinical research now for the last 10 years or also, and we had the chance to do the first-line trial with asciminib, very cautious trial, in combination with the standard therapy. Nobody was willing to promote a first-line trial with asciminib only when we started this trial. Now we have these trials, of course, but here we put it together with the classical TKI, and this trial is still running. Results are remarkable, but I can reveal one major result. The tolerability is not better than of TKI alone. Of course not, because we have this backbone of normal TKIs. So in addition to clinical research, we had a collaboration with Novartis. The ELN, the European Leukemia Net, collaborated with Novartis as a private-public partnership, and this was the UTOS collaboration. Rüdiger Heermann mentioned it yesterday when he talked about Professor Baccarani. We had a big registry, we had meetings as a spread of excellence, we introduced the need for standardization of molecular monitoring, and we had in the first period blood level testing. Later we tried to establish a path to cure with several methodologies to cure more patients. The current series of projects of work package, that means UTOS is still ongoing, is on clonal hierarchy, on BCR-ABL structures, which is led by Oliver Hanschel, stem cell persistence in TFR, and the activity of asciminib on normal hematopoiesis. We talked about this today as well. That means that's a long-standing private partnership with Novartis, a private-public partnership with Novartis. You see here several pictures of gatherings in Berlin of the people who contribute to this study. Again, a very nice teamwork with very nice results, and one result of UTOS is, of course, the UTOS long-term survival, the ELTS score. Harmonization of CML monitoring was important, as shown here on these two pictures. The lead here has been Nick Cross, is still Nick Cross, who helped to standardize a lot of labs in Europe and outside of Europe. What I wanted to highlight here is that we should also think about patients with atypical transcripts. We have detected atypical transcripts over the years, here the example of E682, and we have the chance to monitor these patients when we look at the baseline and the individual slope of BCR-ABL decline over time. That means my request to all the companies who start clinical trials in CML is not to exclude patients with atypical transcripts. They need the analysis, they need the treatment, and they need to be treated outside of clinical trials as well. Therefore, we need this experience. One example of a very nice collaboration within the European investigators on CML is a collaboration with our colleagues in the Ukraine. Irina Diagil sent us samples, slides, from patients who got CML after the Chernobyl disaster, and we did next-generation sequencing on these slides. And we found a huge number of different mutations, many more than in the newly diagnosed CML patients, which I showed you before. That's teamwork again. A very nice collaboration, a trustful collaboration between the colleagues in the Ukraine and our lab. So, and of course, we have Harmony, and Sue Branford introduced this already as a big, big teamwork worldwide to collect as many next-generation sequence data as possible, collaboration between the European Leukemia Net, the International CML Foundation, and the UTAS labs. Of course, we work together also in the ELN recommendation led by Michele Baccarani, as discussed yesterday. I'm proud to be part, or that I was part of all these different versions of the recommendations. And we worked together with 450 colleagues recently on the new WHO classification on CML. The news not on CML, on hematological diseases, of course. The news for CML is that the new classifications will not contain accelerated phase anymore for several reasons, and will define the blast crisis from 20% of blasts according to the data which were discovered by Michael Lausecker and colleagues. And we have teamwork here in ICMLF. We enjoyed this meeting very much. We enjoyed also the online meetings in the last 2 years, but I think it's much better to meet together, as shown here on the picture from yesterday on the right side. That means I enjoy the teamwork with all of you, and we should continue such teamwork in the future in the global way. I thank the German CML study group for their support in our clinical and preclinical work, and I thank my current colleagues in Jena, in my hospital, my department here, for supporting me, for supporting my ideas, for helping me in this support, and for giving the backup to be able to join such conferences. The situation is not easy at the moment in our hospitals because of lack of staff, because of Corona. That means we should be grateful for having the chance to meet at these conferences. It's not easy to juggle the clubs on your own. You need your colleagues, you need your the families around all these institutions to be successful, and I thank you very much for all this collaboration. Thank you.